So today my talk would be focused on our learning in the program we did in collaborative with Northern Hospital in Victoria, where we implemented acupressure for postoperative nausea and vomiting. So that's the topic. Before that, I just talk about the team. So we have a team of experts from RMIT. That's me in Chinese medicine. That's Jenny Layton. She was here yesterday. She's also a registered Chinese medicine practitioner. Sonia Cleary, she's a nurse. And Charlie Xue, which you're familiar with. And this is Dr. Li Pingfeng, and she designed the website. And the rest of the team is from Northern Hospital. And this is Wanda Stelmack, she's the head of surgery. Jason Ma, staff anesthetist. Juris Bridis, and he's the head of anesthesiology. And Judy Crabb, she was the head of a day procedure unit. And Jeanette Etme, head of recovery. And Deborah Bong, I couldn't get her photo, but she's the director of nursing. So I just acknowledge that because it is a multidisciplinary team. Now, the acknowledgement about the funding, and the framework was funded by a seed fund from RMIT. The project, implementation project, was funded by National Health and Medical Research Council in Australia. And we also had funding from RMIT, scholarship to Jenny, and other funding as well from seed band. So quickly, I will talk about we have evidence and why evidence is not leading to clinical practice, and also introduce you to implementation science, and the science initiate a shift from evidence to practice, and also share our learning about our implementation project. And lastly, I'd like to show you the website we developed, where showing the framework, so that anyone who wants to implement acupuncture or acupressure in hospital in future can take this framework and forward. It shows you the step-by-step approach. So we know there's moderate to strong evidence supporting acupuncture in a number of guidelines. These are the few guidelines I listed here, and the ones I highlight in red are the ones very much relevant to today's talk. And they're also in other guidelines. So postoperative nausea and vomiting and postoperative pain, there's quite strong evidence for that. I will talk a bit more about that. So I'm going to, the whole talk, we're going to use postoperative nausea and vomiting as an example to show you how we develop an argument and how we take it forward. So firstly, postoperative nausea and vomiting is not very well managed. And in Australia, there are 2.5 million surgeries a year. And among that, this is 500,000 people will feel nausea or vomit. And with modern medication, the incidence reduced dramatically. But still, there's 150,000 people who would feel that. So what the future will be, how do we move this forward? How do we further improve people's recovery from surgical care? We know the Cochrane review in 2015, they reviewed 59 trials, nearly 8,000 people. They focused on one point, and there's level 1 evidence. Level 1 evidence is the topest evidence you can get to support the effectiveness of acupuncture. And at the end, they actually conclude, which I have not seen this conclusion anywhere else, say no further sham acupuncture control trial is needed to prove acupuncture is effective for postoperative nausea and vomiting. And that is a very amazing conclusion. What they did say is we don't know whether in the modern antiemetic environment, whether acupuncture combined with modern antiemetics will be better than modern antiemetics or pain drugs alone. So anyway, we know from the systematic review, it reduced by nausea and vomiting by a third, reduce medication use by a third. The medication means the antiemetics. And this is the only non-drug intervention in the guidelines. So this is just to show you, this specifically we're taking out from systematic review looking at acupressure. Again, the effectiveness of acupressure was very much similar to acupuncture needling. But there's no head-to-head comparison. Okay, this is just from the data. So acupressure also reduce medication use, reduce nausea and vomiting by a third. So this guideline is accepted all over the world. This guideline is not developed for acupuncture. This is a guideline developed for postoperative nausea and vomiting prevention and management. And Australian and New Zealand College of Anesthetists are using this guideline, and this guideline is developed in America. So as you can see, they were saying when patients come into surgery, we're talking about people undergoing general anesthesia, they need to do risk assessment. People have medium to high risk, need more than one intervention to reduce their nausea and vomiting. And you can see around all these interventions, acupuncture is the only non-pharmaceutical intervention included in this guideline. So that's a very powerful message. So yet, it has not been implemented. So we would like to propose a vision. The vision is, in the future, we were using acupuncture, acupressure further reduce nausea and vomiting rates in the hospital and reduce the suffering of 50,000 people per year. And more importantly, where acupuncture, acupressure can be used together with medication or use it alone. And more importantly, patients have a choice. And how fascinating it is. Patients go into surgery and the nurses say, or anesthetists say, okay, we can use medication, we can use a combination of medication and acupuncture, or it's a long drug therapy, would you like to use it? And people might think the medical field might be very much against this idea. When I was having exactly the same thought. So when I firstly went to Northern Hospital, when I first talked to the doctors about this project, the head surgeon was very supportive. And I said, why are you supportive of an acupuncture project? Because it's a complementary medicine. And she says, the surgical patients are already using lots of medications. The less medication we use for them, the better it is. And I thought, how exciting to know that. So I want to work with her. So we've been working for the last 3 years. And then when I talked to nurses are excited. They said, isn't that wonderful? We can give patients choice. And when they don't have choice, they just have medication, that's it. They even don't, obviously, they have no say what kind of medication they are choosing either, because they don't know much about it. So do patients really want to have a choice and an option? We did this study actually before we did the implementation study. We surveyed the patients in another hospital, 161 surgical patients. And 15% people know about acupuncture could be used for nausea and vomiting, only 15%. But about 87% they will be willing to try acupuncture for postoperative nausea and vomiting. And people who had acupuncture experience are 4 times more likely to try it. Now, mind you, in that survey, we actually tell them we're going to put needles into you. We did show them how long the needle is. So how do we get there? How do we, shift to the future? How do we move to future? So we talked about clinical trials, going to systematic reviews, going to guidelines, and there are a lot of people laid this foundation, have done a lot of hard work and clinical trials. I don't know any of you have done clinical trial. It's a very difficult job to do it. But even when you get into guideline, you still don't get into practice. So because we thought, before I learned this implementation science, I thought, it's easy, we got evidence. Let's go, make it happen. Just tell doctors and nurses, yes, we have evidence, we can use it, you can use it. And then people still don't use it. And now I learned the implementation science, I know why people don't use it. It's not because of their attitude. Possibly. So, why research don't get into practice? This is not just simply applied to Chinese medicine, this is applied to all medicine. So we know even in Western medicine, only 55% recommended care has evidence, and it takes about 17 years to translate research into practice. because this transition is not a natural process, because you ask people to use something else, it's a process of changing cognition and behavior. So we must remember, when we're integrating so-called complementary medicine into mainstream medicine, it is cognition and behavior change we are making. By that, the changes, the cognition and behavior change come from patients, mostly come from medical field, and also importantly, the health system. So this is the cycle. So what is implementation science? So in implementation science, is scientific study of methods to promote systematically uptake of research findings and other evidence-based practice into routine practice, and so that to improve the quality and effectiveness of health services. So it is very important part of evidence-based practice. We have evidence without implementation science is not going to become practice. Now, there are many frameworks about implementation science. I like this one because it's quite simple and it's visual. So Gonzalez showing from evidence to practice what you can think, what could be there behind these questions. So there are government and insurers, and there are hospitals, and there's the providers and patients issues involved in all levels. So implementation science is to actually using a theoretic framework to identify where those issues come from. This is called EPIS framework. That's what we used. And this is called consolidated framework. That is also what we used. So identify different factors. So I just quickly talk about our project. Better have a look. So this is Gonzalez framework on the left-hand side, and this on the right-hand side is our stage. And in 2016, we did baseline, and then we did pilot study, then we implemented, now we are monitoring it. So because we're just trying one hospital, and in that sense, the government things, the insurance, and all these parts are not relevant to our study. So in our study, we really identified what is the hospital current status, and what's the provider, which is who will be providing acupressure, and what the patient wants. So that's what we focused on. So stage one, and we identified team. Who will be on the team? And we also identified which particular acupuncture, acupressure would be implemented, because I will show you later. There are too many. And what do staff and patients think about this change? And is there a need? I mean, does this hospital need to improve their postoperative nausea and vomiting practice? If they're perfect, why do we need that? I have talked to one of the hospitals before, Northern Hospital. That hospital would definitely say, we don't need it, because we don't have many of these problems happening anyway. Our anesthetics are so good, we don't have nausea and vomiting. Not much, not a problem. So we don't need acupuncture. So that's wisdom. So the team, how do we identify team? I think the best way to follow the patient journey. Who actually are involved in assessing the risk of postoperative nausea and vomiting? Who actually involved in managing and preventing it? So if we follow the patient journey, we will find actually anesthetists involved, and nurses before the surgery involved, nurses in the theater involved, nurses in the recovery unit, and also nurses on the ward involved. By the way, when you ask anesthetists how well the post-nausea and vomiting is managed in their hospital, they all say it's great. I'm very good, we have no problem. But then you ask a nurse, they say no, because I'm dealing with them all the time. And I realize why, because anesthetists only deal with patients up to recovery. And after that, they don't see patients anymore. So the patient gets nausea and vomiting afterwards, and the anesthetists had no idea they did. But nurses do, because they are managing that. So what's the ideal form of acupuncture, acupressure to be implemented? We're not asking about what's the most effective form of acupuncture, acupressure. If this practice is the most effective but can't be implemented, it's too complicated. Let's say require you have 3 treatments. and no one's going to implement. It's too expensive, too costing, and too complicated. So these are the type of acupuncture, acupressure we identified from the clinical trials, and we look at a lot of literature and looking at their advantages and disadvantages, looking at the possibility of implementing it. And so why we do that? And we need to show them the evidence as well, because in our survey, more than 80% of doctors and nurses say they rely on evidence. When they take up a new practice, they rely on evidence. Okay, that's what they say. So that's very important, and guidelines. So we formed the team, and we decided to use this acupressure. And this is a C-band. You probably know about that. This is for motion sickness. It has been studied for postoperative nausea and vomiting. And C-band should be worn bilaterally, and with much discussion, and we did a pilot study to see whether it works. And I will show you the pilot study later. So we also did a hospital survey. We asked the hospital doctors and nurses. We also asked patients. So we surveyed 165 doctors and nurses. 80% of them would support this idea, and 88% say they would like to know more about acupuncture, acupressure. This result was really surprising. By the way, we have done a national survey, and the results are very similar. Then we also asked patients. In this hospital, 60% of patients would be winning, so it's a bit lower than the other hospital. As you can see, the hospital and hospital difference depending on the patient population, where they come from. So is there a need to improve the current practice? Yes, we identify about 50 to 60% patients with moderate to high risk. I'm not talking about every patient. 50 to 60 with moderate to high risk, they still have nausea and vomiting. So we prepared. So the preparation really looking at is this acupressure feasible? As it cannot be delivered during the perioperative setting, because that's a very complex setting. Like your bilateral acupressure cannot be used, and we soon find out it could not. You can only use one side, because another side, they always have one side for IV drip, they probably have another side for the arterial line when they need it. So in the end, the other acupressure band just get cut off. So that's what during this practice feasibility study, we did that. And how do we let doctors know more about acupuncture and acupressure? Who were implemented, and things like that. So in a pilot study, we used the FEAM approach. FEAM stands for feasibility, appropriateness, meaningfulness, and safety, and effectiveness. But we focused on the first top three. We look at 73 patients, we follow them up, and we actually developed a lot of strategies. Like one of them was about acupressure band. You can't do bilateral, because it's just not practical. And also the size of the band only fitting with certain people, and we have to know the people's wrist size. And it's not practical for nurses to measure patients' wrist size before surgery. It's too time consuming. They don't have time. So in the end, we invented, or one of the nurses invented another way to do that. We solved the problem. So there are so many things, not just one thing. And we did over more than 20 information sessions to all people involved, many surgeons, anesthetists, and nurses, and to tell them a bit more about postoperative nausea and vomiting. A lot of people actually don't know enough about that, and about acupuncture as well. So other things needed. So during this implementation, we actually realized there are a lot of other things. The first thing is, we know with the guideline I show you, what kind of treatment the patient gets has a lot to do with their risk factors associated with nausea and vomiting. There are four risk factors. Being female is a risk factor. Have motion sickness or previous nausea and vomiting is a risk factor. And non-smoker is a risk factor. And using opioids medication after surgery is another risk factor. So these four risk factors very easily can be identified, in particular the first three. And the hospital is not assessing this risk factor. So the anesthetists are assessing it, but they're not documented. They don't see the need of documentation. So we have to develop the assessment form. We have to develop how are we going to assess it and who's going to assess it. In the end, we let patients assess themselves. It's very easily for them to assess, just ask their gender, their smoking, and their motion sickness. And they have patient consent and who were implemented and training hospital guideline. So if we decide anesthetist do it or if we decide nurse do it, and the hospital has to change their guideline to enable to bring this acupuncture, acupressure in it. Otherwise, it's not in their scope of practice, and the hospital is not going to cover it unless hospital change guideline. And if we put acupressure or anything left there, and this needs to be reflected in all operative checklist, pre-operative checklist, post-operative checklist, and also show it in anesthetic chart. This patient is having this. So not until we do it, we realize there's so many things need to be changed to even just implement this small thing. So in the end, we developed that, patient checklist. In the end, the hospital developed a new guideline, approved it, and the hospital revised their operative checklist. And we were very lucky at the time they were changing their anesthetic chart. We were able to add acupressure into it because it takes them many years to change a chart because it's very costly and time consuming. And for hospital going through the changes, it takes a long time. Many committees need to review it and approve it. So in the end, that's the checklist we use. And so we not only implemented acupressure, we also implemented the POMV checklist by patients themselves. They check themselves, and the nurses in the end, we decide, because it's not practical to have acupuncturists on site to deliver acupuncture to everyone. So in the end, the nurses just applied acupressure to patients, suitable patients on the day. And so we are now auditing the use of the risk checklist, the use of acupressure, and the kind of assess the effect of this band on nausea and vomiting, because it's not a randomized control trial. You're not really controlling anything. So that's where we are at now. So what I try to show you here is evidence for efficacy and safety takes about 20 years to translate into clinical practice. There are so many barriers: the clinician attitude, their capability, patient willingness, and feasibility and safety. For them, the most important is how safe it is for the patients. And our research is try to enrich this process, to understand this process, to provide a framework to implement. So we call that a framework enables seamless integration of acupressure into postoperative nausea and vomiting to transform practice. So now I'm glad I'm really good at timing, isn't it? So now I'd like you to have a look at this website. If you have a phone, you can look at the QR, and we can just look at websites. So. And that's the website, that's the Waverly kindly laundered last night, so thank you to her. And it's brand new website, so you might see there's some mistakes in there. Please let us know. You can email me for that. But I want to quickly just talk with you the purpose of website. So acupuncture and acupressure is not implemented because people don't know how to do that. It's not a natural process. As you can see, I just show you some of, I haven't shown you everything. I just show you some of the things we encountered and how much time it took us to do that. We have 2 people who worked really hard for a year and a half to enable to implement it. Now we're doing the kind of auditing to find out a bit more what's happening. So we want to provide a framework to clinicians develop plans and actions. We want to share our experience because there's no point to everyone repeat exactly the same thing. And so that you go in with the knowledge, you knowing what would be there. Share the resources we develop, I'll show you that, and promote the uptaking of acupuncture in hospital. So if you have, I can just go onto the website. So that's what the website looks like. And as you can see, there's many 4 phases. If you're going down here, it will show you the full face. And say, if you go to phase 1 exploration, on the exploration, there's so many factors. If you say, I want to know, identify the internal needs, and so that's tell you what are the things there. And we even upload our questionnaire here for you to chart the postoperative nausea and vomiting, so you don't have to, because we tried this out for a while to realize what's the best way to do this. So it's actually take quite a while to get this Excel. That's what I mean, we're sharing the resources. So if you go to intervention, every one of them you can click. So with this click, with this click, you actually can see the advantage and disadvantage of using electrical acupuncture and what's the effectiveness rate and how much does that cost you to do this. Because for hospital, all they want, apart from effectiveness, they want to know safety and the cost. It's very important. Yep.
WordPress needles included in any of those options there?
Yeah, WordPress was done by one or two clinical trials, study that. Yeah, the thumb pad, isn't it?
The little press needle.
Yeah, the press needle. Yeah, there's some clinical. We did ask them because that's the one we prefer, but they were so worried about the needle falling off somewhere. They're surgical patients, remember. So that's why we didn't go ahead with that. That's the one we prefer. Because we're doing that preoperatively, we want to do some more prevention. But if you do postoperatively, I think that's a lot safer. They're probably more likely to do it. Yeah. Actually, I would like to try that because we did find the wristband in the end it's quite tight for some patients, and they can get tighter. Especially after surgery, they got a lot more fluid retention. So, so we show you different things. And the assessment of readiness for change. Are they ready to make the shift? So there's, they should take to another thing. We didn't develop that. We actually modify that based on others. So this is assessing different dimensions of changes. Oh, I have plenty of time left. So that's the information you get. If we go back to exploration. And also patients, and how do you assess, how do you select the correct patients? Here, we do that. We've done that already. And preparation. On the preparation, there are many factors, feasibility of the selected ones. So this is the FAME assessment for acupressure for nausea and vomiting. So we developed that. So that's what it looked like. So what do we mean by feasibility? What do we mean by appropriateness like that? Identify time point for acupressure, all sorts of that. This is what we developed self-checklist for. So I thought this is quite innovative to think we could let patients, this is from a lot of discussion with different people and realize we could just let patients check themselves because it's quite easy. They generally understand what this is about. So they can edit up. Quite often, some people will edit up, some may not, but tick this, most people can do that. They have no problem doing this. Yeah, so have a look at the website. Type of patients and surgery, and also important to know what type of patient surgery. Some surgery more likely to cause nausea and vomiting than others, like orthopedic surgery less likely to have nausea and vomiting, or abdominal surgery, in particular gynecologic surgery, because women's already, on high risk for nausea and vomiting. They're more likely to have that. And they all have references, so if you click on that, and that's the reference, you can see. So yeah. That's the website. You can have a look. So that's what we launched last night. So Stu, yeah. Do you have any? So I think that's any more thing I want to talk. Any more thing I want to talk would be. So get in touch with us if you have any questions. Send us thoughts about on the website. And let us know if you want to use the information on the website for your project, or let us know the project you want to know. So that's just help us to understand whether this framework is helpful or not. How can we improve it? Last, each of us can make a difference. Together we make change. That's not what I said, but I think that's what I want to say. Thank you. So, any questions? I think, yes.
Is there any evidence around the effectiveness of acupuncture or pressure for nausea related to chemotherapy?
Yeah, there's quite a lot of evidence.
And in terms of the acupressure, is it more effective if somebody else does it or the person themselves does it?
Yeah, that's a good question. I don't think people assess that. For chemotherapy, the patient might be able to do it themselves. For surgical patients, especially immediately after surgery, a lot of people are so drowsy, they're probably not able to do it. But interestingly, in the hospital, ever since we do that, and even without some patients, not everyone get the bands, as you realize, this implementation. And if people feel nausea, and the nurses would say, oh, just press the point, press the point. And nurses would tell patients to press the point, and then the nurse go to get medication. By the time they come back with medicine, the patient feel a bit better already. So, yeah. So they can press on them. So, yeah. I don't think there anyone done this study. You could try. Yeah. Yes?
Could you please elaborate a little bit on what actually happened in this particular study in terms of how it was implemented? Like what
Okay, so what happened? Yeah, so what happened is because nowadays, not everyone, so patient going to surgery, they usually have to be assessed before surgery, about 1 or 2 weeks before, called pre-admission clinic. But nowadays, to streamline everything, not every patient gets to go to pre-admission clinic. So now, when the patients, but everyone arrive on the day of the surgery. When they arrive on the day of surgery, the clerk will give patients the checklist, ask them to check their nausea and vomiting, the risk, and the nurses will take them in. The nurses will have a look at the list, the checklist, and have a quick chat. If they're on high risk, they will ask, whether they want to use acupressure. But on that form, they already asked them. If they want to use it, if the nurse think they're suitable, like say by suitable, because the wristband is not suitable for people who have carpal tunnel syndrome. And not suitable for people who have arthritis in their wrist, because it's too painful for them. And not suitable for people with wrist size over like 24 centimeters. So then when the nurses decide this person can wear a wristband, and the nurses would put one on the patient, and quickly explain to patient, actually, the reason we use the band is also because the patient can press on that later on, and then they know where to press. So ideally, the nurse should mark where the acupressure band is and put it on, but they don't always do that. So they teach patient, we developed a handout to the patient to say, okay, that's what you do. Then they go into surgery. Then this band, they keep that for about 24 hours. We tell patients, if it's too tight, take it off. And you can always put it back on. Because if they know the dots, they can always put on one. And most patients have no problem doing that. And they feel quite comfortable to be able to do that themselves rather than bother nurses. And medication, once you have medication, you can't take it out of your body. But with acupressure, you can take it off any time. And that's the flexibility is amazing. And autonomy. And another thing we think that's where our next study would go into is the patient engagement. We are engaging patients in this process. When patients go into hospital, they are extremely powerless in surgical procedure. They take their clothes off, they're changing to a gown, and they're completely powerless. We kind of want to give some power back to them. And this is just a small step in a sense, yes. So usually take it out. So those would be charted, so nurse would chart at preoperative checklist. Say this person have acupressure bands, and the anesthetist would put on the anesthetic chart. And when they go to recovery, the recovery would tick on the postoperative checklist as well, whether they still have the band there. And then this should be on the drug chart. Now, we haven't audited that part. So acupressure should be on the drug chart as the nurse initiated the intervention. Yes. Any other questions? Yes, Stephen.
So once this trial is over, has the unit kept it running at all? Have they kept this in their process, or is the trial done and that's just back to business as usual?
Yeah, that's a really good question. That's what we mean post-implementation monitoring. So with implementation, they should become their normal practice. So at the moment, as far as I understand, because we left the hospital, we let them do it. As far as I understand, the checklist is still being doing, and the acupressures, depending on who is on duty. Some nurses more likely do it than other nurses. Yeah. So that's another thing. That's more different strategy needed to actually sustain the practice. Yeah. So we kind of engaging the hospital in the research, and that's a good strategy to continue with that. Yeah. Good question. Any other questions? No? I'm on time. Thank you.